oral cavity up to the anal canal. And but for endoscopic biopsies, we usually get from esophagus up to the more or less up to the rectum, and anal canal biopsy is seldom necessary, and as possibly the disease is slightly rare. And so most of the slides which I will be dealing with would be from esophagus up to the rectum, colorectum. And so this is just to cover briefly about the different layers, though this is basically luminal, which we are going to deal with. So it does have 4 layers, that is the mucosa, submucosa, muscularis, and serosa. And I think this is we all know about. Stomach is slightly special, different, because it has an extra muscle, muscularis propria, that is a circular layer, and also greater and lesser omentums. Now, esophagus, you all know, I mean, you know it better than me. The length is from the, usually measured from the incisor up to the GE junction, which is around 40 to 44 centimeters in length. And also, it is important to mention when you are doing a biopsy from at what particular centimeter you are taking the biopsy, because as a morphologist, it's all the time more comfortable for me to interpret if exact site of biopsy is mentioned in the proforma which is accompanying the biopsy sample. So this is a transverse section at low power view of the esophagus. So we have the mucosa, we have the lamina propria, we have the muscularis mucosae, the submucosa, and the 2 muscularis propria. And according to what textbook one is using, some textbook writes there is esophagus does not have submucosa, but in my experience, I have seen submucosa all the time in any kind of given biopsy. There are submucosal glands as well. And so this is a normal stratified squamous lining of the esophagus. And this is roughly one can divide into 2. One is a mature layer, another one is a basal cell layer or the regenerative zone. And then we have the papilla, the papillary blood vessels, which usually normally also can extend up to the 50% depth, but some textbook will write almost up to 3/4. But I think that is slightly too deep. So normally we tend to see it almost slightly less than 50% of the whole thickness of the mucosa. The papillary blood vessels can be seen along with the part of the basal cell layer. And there is seldom any inflammatory cells in a normal mucosal biopsy. And now we come to the reflex esophagitis, which is a common problem and where there is a whole lot of biopsies usually is carried out routinely in order to exclude any kind of associated dysplasia or malignancy or any other unexpected situations. And so now here, as we were talking about the papilla, here the papilla is extended more than half of the thickness of the mucosa. It is coming up almost up to upper 1/3. And the basal cell layer, as one can see, it is hyperplastic. Normally, it is around 1/5 or 50% of the whole thickness of the mucosa. And so it is really definitely increased and almost about 2/3 of the whole thickness of the mucosa. And in this low power view, one cannot really see much of the inflammatory cells, but in the adjoining one could see that there are multiple eosinophils which are present. Along with that, one could also see intracellular edema, which is another constant accompanying feature in a case of reflux esophagitis. And some more photograph where one could see that the eosinophils have disappeared here. One could see more of a darkly stained lymphocytes with a few scattered neutrophils. So depending on the duration of the disease, one will have this kind of inflammatory cell infiltration. So eosinophil is not all the time a must in order to make a diagnosis of reflux esophagitis. Along with that, one can also have lymphocytes. And if there is associated ulceration or some other superadded in infection, especially, then you can one can also have neutrophils. And now coming to the eosinophilic infiltration in the esophagus again. And so an important differential diagnosis of eosinophils in esophageal biopsy for reflux esophagitis is eosinophilic esophagitis, as we all know it. And usually the textbook writes that should be more than 15 eosinophils per high power fill in order to make a definitive diagnosis of eosinophilic esophagitis. But there is a lot of controversy about this particular diagnostic criteria. But as a pathologist who has been working very closely with gastroenterologists, I understand that gastroenterologists all the time they treat the patient for reflux first. Then only when you come up or one comes up with a definitive diagnosis of eosinophilic esophagitis before starting of any other stronger medicine, which possibly is the best way of approach for a patient. And now coming to the criteria of mild esophagitis, moderate esophagitis, and severe esophagitis. Sometimes it may be mentioned in your report or in the report that there is mild changes of reflux esophagitis or moderate changes of reflux esophagitis and severe esophagitis. For mild, there is usually the blood vessels usually is not really rich up to or the papillary blood vessels do not really come very close towards the surface. There could be certain degree of vessel cell hyperplasia and also just a few scattered inflammatory cells. And in moderate changes, there would be much more extensive degree of changes along with the marked intracellular edema and much more significant visual cell hyperplasia, and in severe, you will be associated degenerative changes of the squamous epithelium along with heavier inflammatory cell infiltration. The inflammatory cell infiltration can be both eosinophils or maybe only isolated eosinophils and lymphocytes, and also can be intermix of variable amount of neutrophils. So the type of the inflammatory cells is not really it's not really the only criteria to see that whether there is presence or absence of esophagitis, reflux esophagitis. The more important are the changes in the stratified squamous epithelium. And now coming again to the more severe changes of reflux esophagitis is the development of columnar line esophageal mucosa. This columnar line esophageal mucosa could be of this gastric type, that is a mucus type of epithelial cells, or it could be associated with goblet cells. And as one can see that here, a lot of scattered goblet cells is intermixed with other types of mucus type of epithelial cells, along with changes of reflux esophagitis and the adjoining mucosa. And this here also one could see little bit of columnar line mucosa, but in the subepithelium there are multiple glands which showing goblet cell metaplasia. So various types of metaplastic epithelium could be seen at the lower end in columnar line mucosa. Is not necessary that it has to be restricted only along the surface epithelium. The surface epithelium has to be replaced by the columnar mucosa. It can also be seen in the deeper submucosal glands. And the changes, the type of epithelial cells can be all the time highlighted much better by special stains, which one can use Ellison blue and PAs together in the same slide. The Ellison blue would stain the goblet cells blue, and the mucus type of or the gastric type of mucosa will take up the PAs positivity. And these are the different types of special stains to demonstrate the mucus, the acidic mucus. And so any kind of mucus, that is the silo or the sulfomucin, both would be stained with Ellison blue, which is done at pH 2.5, and the Ellison blue, which is done at pH 1, would stain isolatedly the sulfomucins, which would also be stained by the high iron diamine. And now coming to the much more extensive changes of this metaplastic epithelium. Here, there is in this particular photograph, there is no changes of any dysplasia, but in the next one, there are development of dysplasia. Dysplastic epithelium can be seen, which is of low grade. And in this particular section, there are high grade dysplasia. And in the last photograph, there is development of adenocarcinoma. These are some of the features which one has to look 4 in a given biopsy by carrying out step serial section, which is a must in any kind of a small endoscopic biopsy for metaplastic epithelium. And now, again, coming to the other type of dysplasia that we were talking about, the columnar dysplasia, and now we would look into the squamous dysplasia. So the squamous dysplasia may be classified into mild or the low grade. A low grade will include both the mild and the moderate, and this high grade will include or will be synonymous with a severe dysplasia. You call it mild when the dysplastic epithelium or atypical epithelium towards the basal cell layer, there is increase in the number of cell and the nuclei are showing atypia. So this is how one try and differentiate from basal cell hyperplasia. In basal cell hyperplasia, one will not have atypical changes in the nuclei. And in moderate dysplasia, it is almost half of the thickness of the mucosa would be occupied by those atypical looking nuclei. And in severe dysplasia, it is almost full thickness. This is a pictorial diagram to show the extent of these atypical cells. In high grade, it is intramucosal. It is restricted to the stratified squamous lining. And in intramucosal, it is also may also involve the laminopropia. Submucosa is involved. Muscularis propria, when the muscularis propria is involved. Then when it is extending much more deeper into the adventitia, then it is adventitial involvement. It really has to be stated. Accordingly, there would be staging of this particular tumor. And now this is the microphotograph. Again, this is high-grade dysplasia or severe degree dysplasia versus carcinoma in situ. In carcinoma in situ, usually the term is used when there is hardly any remnant of normal-looking stratified squamous is seen in the mucosa. And this is an early invasion into the lamina propria. This kind of breeding in a given biopsy is very important with the advancement of submucosal resection, which is a practice in many of advanced centers where there are capable gastroenterologists are there. And so I think identifying this extent of involvement, the type of the dysplasia, and also whether it is carcinoma in situ or early invasion into the lamina propria up to the muscularis mucosae and the early part or the superficial part of the submucosa are very important factors to be commented upon. And also as a gastroenterologist, you must insist your counterpart, that is a pathologist, to make comment on all these factors so that you should be able to decide what kind of treatment or therapy modality can be given to the patient. And now, in addition to those, there is something called coilocytosis. And this is very frequently seen in any form of stratified squamous epithelium lining. And this is because of human papillomavirus infection. This particular condition is very popularly spoken about in cervical cancers, but these are also seen in upper aerodigestive tract squamous lining epithelium. And this here one has a perinuclear halo where the cytoplasm, rim of the cytoplasm is pushed towards the periphery. The nucleus becomes irregular, hyperchromatic. Sometimes one can also see some of inclusions. And there could be some multinucleated cells because human papillomavirus is a type of herpes virus. So they also behave like herpes virus. And so this is another feature which very frequently I have been seeing in upper aerodigestive tract, especially in esophageal biopsies. And these possibly like in cervical cancer, they are also known to be oncogenic. So they may have a important role in the development of esophageal squamous cell cancer. And even I think some of the studies have gone to the extent of saying that even adenocarcinomas can also be this HPV can also be responsible for the development of adenocarcinomas. So it is important to look for all these features. And so as a clinician, you must also be aware. And sometimes this is a kind of a clinician and the lab which is correlating, and one has to have a good kind of understanding, and there has to be a round which should be conducted and all these points to be discussed. And you can all the time ask or raise these questions to your pathology counterparts, so that the pathologists should also be able to look for or would be more aware and would be more careful to comment on all these factors, which does have important roles. Now coming to the next organ, that is the stomach. And stomach is a big organ, and as we already seen, it does have the mucosa, muscularis mucosa, then submucosa, and the muscularis propria. So the stomach is a complex organ, just not only because of its size. We know that histologically it can be divided into three parts. One is the cardia, and the second one is the fundus and the body, and the third part is the pyloric antrum in endoscopic biopsy. And so the cardia is a slightly controversial component or part of the stomach, because the cardia mucosa, histologically, there is nothing really fixed about. This is what I feel is very, very representative for a biopsy from the cardia of the stomach. Cardia of the stomach tends to have they are usually slightly thinner compared to the other parts, but it may look very similar to pyloric antral or antral biopsy, because it does have the mucous types of glands and the surface lining the fovula. This is the pits, the fovula or the pits. It's almost half the thickness of the mucosa. And so when one is going to talk about stomach, this is a gastric mucosa. In an endoscopic biopsy, what one gets is the mucosa and a part of the muscularis mucosa. Sometimes if there is some disease or submucosa is involved, and one will get in an endoscopic biopsy a part of the submucosa. But usually what we get is the mucosa and little bit of the submucosa. And now I do not know how many centers do the orientation by mounting endoscopic biopsies on filter paper. So it is very essential to mount them on filter paper so that the mucosa or the biopsy can be oriented at the time of processing and embedding or the paraffin block is made. But orienting the biopsy on filter paper in the endoscopy room is not the end of the story. Your lab counterpart, the technical staff, the pathologists should also know how to handle an endoscopic biopsy, an oriented endoscopic biopsy mounted on filter paper, because the critical stage of handling of a mounted specimen, filter paper mounted specimen, is at the time of paraffin block making. That is the most important step. So they also have to know how to handle it. Then only the orientation, the purpose of the orientation will be served. And so this here we can see that this is a nicely oriented biopsy. And so one could see the gastric pit, the surface epithelium. So in the gastric, in any kind of luminal biopsy, when you're talking about the surface epithelium, you're talking about the surface epithelium, totally, not the whole mucosa. This is mucosa, this is surface epithelium or surface mucosa, lining mucosa. Then you talk about the gastric pits or the fovulae, you talk about the lamina propria, you talk about the glands. In the stomach, the glands are very important. Different parts of the glands will have different characters, and so we will come across and come through all those remaining part of the stomach, and we will get to learn about those different types of glands. And so here in the cardia, usually one has the mucous types of glands. That's why I say it is very similar to the pyloric antrum, but sometimes one can also have quite a bit of parietal cells, that is a fundic component as well. And this is the Z junction stratified squamous lining. This is the cardiac component. And here the number of the glands have increased compared to the previous one, but still they are mucous type of glands. And now this is a pictorial diagram to represent the antral unit, the fundic unit, and different types of cells. So this is a foveolar component. Here one does have in the stomach. The glands are slightly different from the rest of the GI, because the stem cell usually comes up towards the base of the fovulae. Then one has the parietal cells or the auxiliary cells, endocrine cells, then the enteral glands or the chip cells in the body component. So this is how usually a gastric gland, depending on the site, would arrange. So the chip cells in the deeper part in the body region, body and fundus, then the parietal cells, the stem cells towards the neck. base of the fovellae. That is an important point to be noted. And now this is a low power microphotograph of a body or the fundic mucosa. And so as we already seen in the pictorial diagram, one has the fovellae or the pits, and then the neck would be somewhere here, the isthmus and the neck would be somewhere here, and then the parietal cells and the chip cells and the deeper part. And the staining character is slightly different. The parietal cells are more pinkish, the chip cells are slightly more bluish or amphophilia, we call it. It's not really basophilia, but it is amphophilia. This is high power view of the chip cells here. And this is another high power view to show the difference between the chip cells and the parietal cell. These are the parietal cells, not the chip cells. Here, this is the chip cells, and these are the parietal cells. The chip cells are slightly smaller, parietal cells are larger, more pinkish, granular cytoplasm, finely granular cytoplasm. And so normally, gastric mucosa seldom has any inflammatory cells. So this is another very characteristic feature to be differentiated from remaining part of the intestine. Lamina propria contains certain amount of inflammatory cells normally, but in stomach, the lamina propria seldom contains any inflammatory cells. Different textbook will say some 1 or 2 or 3 or 4, but in my experience, especially we do have autopsy backup in our institute, and so normal mucosa does not have any inflammatory cell infiltration. It would have little bit of mesenchymal component, and that's it. It doesn't have anything more than that. And now this is the special cells or the endocrine cells, which is called the enterochromaffin cell, which contains special endocrine or special components, compounds. With all these can be highlighted or identified by using special primary antibody, which are available by carrying out immunohistochemistry. On H&E, the routine staining, one will not be able to differentiate one from the other. And now coming to the antrum, and here the antrum, one could see that the fovea are very deep, and these are the antral glands, and which is mucus type. And in this mucosa, there are certain amount of inflammation is there because this is a endoscopic biopsy, so it's not really a normal antral mucosa. This is mildly inflamed antral mucosa. And here also in antrum also one does have those special cells, which are neuroendocrine cells, which can be highlighted by using appropriate or targeted primary antibody, and one can identify them in an immunostaining section. And now coming to the gastritis, we will not go very much in depth, but I'll cover a little bit of gastritis. So it can be roughly differentiated into acute, active. And this acute and active, I would say that would be cool. The diagnosis can be established only with the availability of the clinical history. And if the acute, then in both conditions, there will be neutrophilic infiltration. There may not be much changes of chronicity, but it could be an active also where the patient might have had it for quite some time, or maybe just a few days old. And so this particular term, depending on the duration of the disease, can be used interchangeably. Then we also have chronic gastritis, atrophic gastritis. Chronic gastritis can be either superficial or full thickness. The superficial ones are believed to be reversible. The full thickness gastritis are believed to be non-reversible, which usually tends to progress further into atrophic gastritis. So atrophic gastritis can be patchy, multifocal, depending on the etiology, underlying etiology, or diffuse. Now coming to the acute or the gastritis, and acute gastritis could be an erosive, where the surface epithelium is eroded off, not the mucosa. So sense and disease of the surface epithelium in the stomach is usually called either denuded surface epithelium or erosive gastritis, depending on the kind of histological findings here. One could see the little bit of degenerated or necrotic material along with fibrin and RBCs. And then there is edema associated. So one will label this particular biopsy as erosive gastritis. And then in the next two, one sees a lot of neutrophils which are infiltrating into the glands, but apart from that, there's not much of fibrosis apart from other changes. So these can be labeled as acute gastritis. Acute gastritis could be infective, non-infective, and the etiology can be of various types. And now there is something called pill gastritis, which we do come across quite frequently. And so one has to be aware of this particular condition. And the commonest medicine which can produce this particular condition is iron tablets. And then here one could see that along with the erosions, edema, inflammation, fragmentation of the glands, and it is very friable. So there is a gap. This is an artifact because of the friability during the time of the handling, cutting, and staining. There is a kind of artifacts. But here one could see that along with the erosions and inflammation, there are some kind of pigment which are present or sticking onto the surface and also within some of the glands. These can be highlighted with pearl stain. If it is iron, then it would be pearls positive. So, and also this could be seen within deeper down within the glands. And so a definitive diagnosis can be given if pearls is positive, but there are so many other drugs and so many other types of crystals which can also be present, which possibly may not be identifiable in a given biopsy. And now this is a chronic follicles, but those are usually without any other associated mucosal inflammation. One can have those lymphoid follicles on the deeper part of the mucosa. So these follicles would be associated with a chronic inflammation. And this is another area to show the presence of lymphoplasmacytic cells and with focal activity. And so this is a chronic gastritis, a full thickness gastritis, chronic gastritis. And these are usually very frequently in our setting. It is because of infective association or infection related. That would be the H. pylori. H. pylori infection is most frequently seen involving the pyloric antrum. Involvement of the pyloric antrum is because of a strategic position of the pyloric antrum, not otherwise. Also, remaining part of the stomach can be involved or can similarly be involved by H. pylori infection. And so here, the importance of the chronic gastritis I have just put down in few lines, leading to eventually to mucosal atrophy and intestinal metaplasia, usually in the absence of erosions. These changes of atrophy and intestinal metaplasia, the importance is that they are considered as pre-malignant condition. That is the reason why identification of chronic gastritis is very important. And now this is the multifocal H. pylori infection, which can also involve different parts of the stomach. And H. pylori and gastric pathology. H. pylori can produce any kind of gastric lesion, including lymphomas and cancer. And here I have put arranged 4 photographs. There are various types of stainings available for H. pylori demonstration. H. pylori, I hope you all know that what is it? It's gram-negative or gram-positive. You may put it down in your chat box. I just want to cross-check your knowledge. I'm sure that many of you would be aware of it. This is on H&E. H. pylori is very tiny, S-shaped. It's not spiral, but it is an S-shaped curve organism, which is around 6 to 7 micron length. If you log into the Google is going to give you that H. pylori length is just 4 micron. No, it's not 4 micron. It is 6 to 7. It is comparable to lymphocyte. It's a curve, inverted S, and around 2 micron width. And so this is in this is in tall blue staining. And this is a silver staining, and there are antibodies available to stain the H. pylori. So this is immunohistochemistry staining. But if staining is proper, we say in pathological term, blue or well differentiated staining, we call it H&E staining. H. pylori can be very easily identifiable only on H&E stain. We seldom use any special staining because they can be seen. So only when we are suspecting the H. pylori infection to be there with the activity and we are not able to identify on routine standard H&E stain, then only we go ahead and ask for the special stains. Otherwise, routinely in our center, we do not do any kind of special stains. We report H. pylori, presence of H. pylori on HNE. And H. pylori, I hope you all know that it does not invade into the mucosa. It is present on the surface, entangled within the mucus layer. And I hope you all will know this. If you are not clear about this particular concept, I will not go into detail. You have to read. This is important to understand why H. pylori remains within the mucus layer. Okay, and how does it produce all the changes, all the different types of lesions in the stomach? I think one needs to read about this in detail. And so this is another organism. This is stomach gastric pit, another organism. Any of you can identify this organism, which is slightly different, longer than the H. pylori, which we have, appear to be having this spiral, much longer. You may write it down in the chat box. I just want to test. But this is not H. pylori, but it is similar. It belong to the same family. It will have similar kind of clinical presentation, but this particular organism is zoonotic in origin. So the person will give you a history of exposure to wild animals. So this is very characteristic. It is a rare situation, and one has to be aware of to pick up this particular infection. One should be aware of it. And now coming to the chronic gastritis changes here, this is the mucosa is thinned out. It can be from any way. It could be fundus, body, or it could be from pyloric antrum, this mucosa. Without the site being mentioned, it is not possible from the atrophic changes to say that from where this mucosa could have been taken, the biopsy could have been taken. Here there is very severe, extensive loss of the glands and lymphoid follicles. The fibrosis is seen only in the deeper part, otherwise the remaining component is loose stroma with little bit of goblet cell metaplasia, and this is grossly hyperplastic foveolae. The surface epithelium is intact, but this is an atrophic gastritis. And here, these are the, again, the goblet cells which have been highlighted better on the spatial stain. And now this is another pattern of atrophic gastritis in contrast to the other one which we just seen. And here there is replacement fibrosis, extensive replacement fibrosis, and the glands are also is very extensively coiled. And there are few just like the enteral glands, mucous glands are left over. The presence of the mucous glands will not really tell me that this is from antrum. In atrophic gastritis, even the body mucosa can show pyloric gland metaplasia. So until and unless you as a gastroenterologist, the endoscopy is telling me that this particular biopsy is taken from antrum, I will not call that this atrophic mucosa is from antrum. So mentioning the specific site of biopsy in the biopsy form for a better interpretation with proper history is a must. You will get a better pathological report if you give a better history and all the essential information in the requisition form. And so you must do that so that you get a good report from your pathology counterpart. So whenever one is having this kind of atrophic changes, in addition to the metaplastic epithelium, one also all the time has to look for dysplastic changes in the same biopsy. And so if one is suspecting this is slightly blue staining, but this will be because of the regenerative atypia, but the changes in this particular focus from this is quite different. Here there's a lot of nuclear enlargement, nuclear stratification, and at places the nuclei coming up towards the lumen. So most of the area, this is a low-grade dysplasia, but focally it is a high-grade dysplasia. And so dysplastic changes have to be all the time looked for in an atrophic mucosa in addition to the intestinal metaplasia. And this is another atrophic mucosa. It looks very, very cellular here. But in addition to that, there are large areas of fibrosis. The big cluster of lymphoid tissue, then there are large clusters of some glands in this low power, along with a lot of disorganization of the surface mucosa, that is a fovellae. And so this on high power, somewhere from here, and there were goblet cell metaplasia, and also this particular gland where we have these clusters of this particular gland. On chromogranin staining, these have been highlighted as ECL cell hyperplasia. I hope you understand the difference between EC cell and ECL cell hyperplasia. ECL cell is the metaplastic epithelium. Normally users have a few scattered 1 or 2 cells. They are not really very prominent in a normal mucosa, but they are metaplastic cells, which usually give rise to the maybe multifocal carcinoid and atrophic mucosa. So it is important to identify this group of cells. And here this is a chromogranin staining, but sometimes they may be chromogranin negative, but one has to carry out multiple immunostain, and in one go, I usually ask multiple immunohistochemistry staining, including the chromogranin, NSG, gastrin, and cyberotophysin. And also, if one has these kind of proliferating cells, one cannot forget to do the Ki67, which is another proliferative marker, and which become an essential decision maker to say what is a proliferative index of this metaplastic epithelium. And so sometimes it could resist only gastrin positivity. Chromogranin would be negative, gastrin may turn out to be strongly positive. And so these ECL cells are gastrin positive cells. So it's going to mean something totally different. The etiology would be different. So we will not go into that detail, but you must read about all these things. When you have gastrin positive cells proliferating in background of atrophy, when do you have synaptophysin positive cells in the background of atrophic gastritis? Just not only the chromogranin. Chromogranin is the most commonly positive marker, but others also can be positive depending on the situation, and it has different connotation and indication. As a clinician, when you are going to follow up, you have to do further investigations depending on which marker is positive in the immunohistochemistry. And now I think that much for the stomach. Now we come to the duodenum. And so you all would be better well versed than me. This is the duodenal mucosal folds, and this is the Brunner's glands. Small intestine cannot be differentiated on endoscopic biopsy one from the other, except by the mere presence of these Brunner's glands. So presence of the Brunner's glands tells us that this particular biopsy has come is from a duodenum, not otherwise. All would be looking the same. All will have the villi, all will have the crypt. And now you should be clear about the crypt epithelium and the surface epithelium. The villi has a neck or the crypt. And so the crypt epitheliums are different. The surface epithelium or the villi epithelium, the epithelium lining the villi is the surface epithelium. And so in the deeper part of the crypt, one gets the Pennant cells. Otherwise, the remaining parts are goblet cells intermixed with the absorptive or the enterocytes. And this is a closer view. So this is the crypt. The lower 1/3 is regenerative zone. As it matures, it goes above, and the surface epithelium are the mature enterocytes intermixed with goblet cells. So goblet cells in the foregut is roughly around, we say around 5 per 100 enterocytes. And intraepithelial lymphocytes are also normally present in the foregut. We see that roughly about 20 intraepithelial lymphocytes per 100 enterocytes in the foregut. And now the same thing can also be seen in the hindgut and the reverse, in the reverse format, like 5 intraepithelial lymphocytes per 100 enterocytes and 20 goblet cells per 100 enterocytes in the hindgut. So the reverse is supposedly true for foregut and hindgut with respect to the goblet cell and the intraepithelial lymphocytes. And the laminopropia, as when we were talking about the stomach, is normally also contains certain amount of lymphocytes and plasma cells. And so when one is going to talk about the inflammatory condition, ideally one should say whether it is mildly increased, moderately increased, or heavily increased, because normally also one can see certain amount of them. And so grading possibly is ideal way of reporting. And so this is just another area to show that all the time, this is villi will not be long and tall like this. Some villi may be stunted, broad, but that doesn't mean that this is an atrophic villus or villus atrophy. So the biopsy has to be properly oriented. When do we call the biopsy is properly oriented? At least one going to assess depending on the crypts, not the villi, because villi are unfixed structures. If you are doing a biopsy because of a malabsorptive condition from the duodenum, you are expecting certain degree of changes in the villi, then you are not going to use the villi as the comparison. You are going to use a fixed structure, which is the crypts. So there has to be at least minimum 3 or 4 full-length crypts. Full-length crypt. This is what is called full-length crypts. It has been properly oriented, and so one could see the whole length of the crypts. So at least 3 or 4 full-length crypts should be seen in order to say that the biopsy is properly oriented, irrespective of presence or absence of the muscularis mucosae. I am also aware that some of the textbook writes that presence of muscularis mucosae is more than enough evidence to say that the biopsy is properly oriented. I totally disagree with that. And I think with my experience, I can speak very boldly. And I think that presence or absence of muscularis mucosae does not tell you the biopsy is properly oriented or not. So is the crypts. And then only one should say that whether the orientation is proper or not. Then only one can go ahead and try and interpret crypt-villus ratio or stunting of the villi, not otherwise. And now see, this is poorly-oriented biopsies. And so in a poorly-oriented biopsy, I'm very sorry to say that many pathologists will report this as subtotal villus atrophy. Whenever you have subtotal villus atrophy, let's talk about celiac, a burnt out case is totally different. Otherwise, active celiac cases, there has to be associated heavy inflammation when you have this extent of villus atrophy. There's hardly any increase in the significant number of increase of inflammatory cells is not there. And so this is because of the poor orientation. Here also is another photograph where it is a poorly oriented. Here also another one. Usually in a poorly oriented biopsy, what I use is this kind of obliquely cut villi. Sometimes you can have some few transversely cut villi. If I start seeing those, then I say that there is no significant villus atrophy. When there is significant villus atrophy, you can never have a transversely cut villi, obliquely cut villi. But a setting like this, I will all the time go ahead and ask for step serials. I will get to see many more sections than some of obliquely cut, transversely cut villi will come up. Then I would be comfortable to say that there is no significant villus atrophy. And so now coming back to the normal morphology, intraepithelial lymphocytes we were talking about here. The intraepithelial lymphocytes are darkly stained round structures. The textbook writes that they are present on the deeper part of the mucosa. No, it's not. Here also one can see that they are present towards the surface. So they can be anywhere, but in order to differentiate from the nuclei of the epithelial cells, the nuclei of the epithelial cells comparatively are lighter, and also they are not really rounded like the intraepithelial lymphocytes. But intraepithelial lymphocyte need not be all the time rounded. It can be segmented like here also. And in a normal mucosa like here, the goblet cells are very uniformly distributed. And then the enterocytes are seen very well. There's no degenerative changes. It's intact enterocytes. And this is here one could see the breast border, which is highlighted much better on the PS positive. Breast borders are not light microscopy features. These are electron microscopy features. This is God's way of increasing the absorptive surface. So God has given us the folds. God has given us the villi. God has given us the microvillus. So in that way, I believe Schlesinger writes, whoever reads Schlesinger will be able to tell me what is the available total area of available absorptive surface. It is written in Schlesinger. I know about this. And so, this The breast border, you may write down, whoever knows what is the size, how big it is in the chat box, but it is given in Legendre. And so the breast borders are pH positive. This is high power view to show the breast border, which is pH positive. It's a thick band, like a thick band like pH positivity. Even the goblet cells are pH positive. Enterocytes are not pH positive. Okay, so here we have some more photographs. There are 3 photographs. Actually, Navneet, can we just remove? Okay, I'll do this. Okay, there are 3 pictures of variable grades of increase in intraepithelial lymphocyte. Here, this is also increase, and another way increase in intraepithelial lymphocyte is inflammatory process. It is a T cell mediated inflammatory process. So the inflammatory process will not happen isolatedly. So increase in intraepithelial lymphocytes will not happen isolatedly. There would be other changes as well. Here one could see that there is almost near total loss towards the tip of the villi goblet cell. There is hardly any goblet cell. One could see the goblet cell, few here and there. And also there are degenerative changes which as identified by vacuolization of the cytoplasm, just not only increase in intraepithelial lymphocytes. And so associated changes are all the time will be identifiable. Even the breast border become very fuzzy. So these are all degenerative changes which are associated with increase in intraepithelial lymphocyte. So increase in intraepithelial lymphocyte, I repeat again, does not happen isolatedly. Other changes also will be taking place side by side. Compared to the previous one, here also mild increase in lymphoplasmacytic cells in the lamina propria. And here again, one could see that the increase in intraepithelial lymphocytes is more compared to this particular villi. And here this is maximum. And here hardly the enterocyte height has also reduced. There's a lot of degenerative changes, and there's marked increase in intraepithelial lymphocytes. Actually, and to be honest, I do not really sit and do the counting per 100 cells. I roughly assess all the time. It's not possible in routine biopsy when you have to start reporting 80 to 100 cases, new case every day. It is not possible to do the counting. But I think one can roughly look at this history. One can say that this is maximum, heavily increased, moderately increased in this one, and this is mildly increased. So this is the way that I assess, but this one can develop over the years. A newcomer will not be able to do this. A newcomer possibly has to spend more time to do all these kind of things. And so here also one could just see that there's mild increase with some degenerative changes and of the surface epithelium, but the inflammation is quite increased in the lamina propria. So this biopsy also is not really normal, and the inflammatory cells also is increased in the crypts. So it's just not only along the surface epithelium, even at the deeper crypts also is showing increase in intraepithelial lymphocytes. And so possibly, so this is something much more than just the something which is injury is producing to the villi because of the content of the lumen. It has to be something much more because the crypts are also involved. So one can assess in this way, and the lamina propria inflammatory cells also is increased. And so one can assess in this way and try and look for the underlying etiology. Some of the conditions like graft versus host disease is one condition which usually involves the crypt. Apart from that, there are many other conditions, but GVHD of the intestine is one condition where it is crypt-oriented, or they attack usually the crypt epithelium. And so that is one important condition which should come up. Though it is possibly is much milder, the changes is not really very significant. And now one thing which one has to look for in the duodenal biopsy is the parasite. This is one thing which you all should all the time expect this. Maybe the patient may be symptomatic, maybe asymptomatic, but this has to be all the time commented upon, the presence or absence. And here this is, some of them are sickle shape, and here this is a face-on, which is racket shape. One could see the 2 eyes, the nose, and then I think that's much which one can see in light microscopy. They usually produce diarrhea or the loose motion because they usually is a kind of mechanical. Yeah, obstruction to the absorption because of they attach along the surface epithelium. So this is giardia, very characteristic giardia. So D2 biopsy, a comment of the presence or absence of giardia is expected all the time. It has to be made by the pathologist. They cannot do away with this. And now coming to the colon. Now this is the crypt or the colon. And so this is the normal mucosa. Beginning to this muscularis mucosa, little bit of submucosa is here. Normally all the crypts, both in the small and also in the large intestine, the crypts sit directly on the muscularis mucosa. There is no gap, no inflammatory cells, no gap. And so whenever there is increase, like here a little bit, which is a gap is coming up, one will say that there is increase in the deep mucosal gap. That is indicative of any kind of chronicity, chronic disease, inflammatory disease, just not only IBD or ulcerative colitis. But see the number of the goblet cells here compared to the foregut. Goblet cells are much more here. That's why goblet cells were considered to be much more in the hindgut compared to the foregut. And that's why that 5 per 100 and 20 per 100 ratio was coming up. And inflammatory cells, again, in the lamina propria are present. So this is a properly oriented colonic biopsy where full-length crypt could be seen, and the surface epithelium is the epithelium between the two crypts. So the crypt epithelium and the surface epithelium should not be clubbed together. And so if the surface epithelium is absent, one will say there is denudation of the surface epithelium in order to say that there is mucosal ulcer. The whole thickness of the mucosa should go away, give away, should be replaced by inflammatory cells or granulation tissue. So this mere absence of the surface epithelium will not qualify for the diagnosis of ulcer. This is what happens in a poorly cut colonic biopsy, where the glands, most of the time we keep on seeing the glands in a colonic biopsy. That is because of the pole orientation. And so these are the crypt compared to this here also, some are not properly oriented. And so one starts seeing the glands. But in a properly well-oriented biopsy, you will see the full-length crypts with the surface epithelium in between the two crypts. Now, in a casual look, any of you wants to try, you may write down your answer in the chat box. In a casual look, this colonic biopsy could be from anywhere. Usually it is rectosigmoid because you all tend to do a sigmoidoscopy. That is the easy way out. You do it in emergency basis also. And so this is a colonic biopsy where one could see many lymphocytes. Scattered eosinophils are there definitely, but this is mainly lymphocytes. And also see the number of the goblet cells have reduced grossly. We were seeing the goblet cells in the first, that normal biopsy. So there is mucodepletion, there is gross increase in intraepithelial lymphocytes, more on the surface and also towards the crypts. And there is increase in inflammatory cells in the lamina propria, including few scattered eosinophils. So, and then maybe that there is little bit of neutrophils also, like a cryptopsis, but this amount of lymphocytes with a normally aligned crypt, there's just one condition, lymphocytic colitis, nothing else. Maybe that the patient already was on treatment, some kind of antibiotics or something. Many of the antibiotics produces very strong tissue eosinophilia. So these eosinophils could be as the result of that, may not be really anything as the primary disease for this particular individual. So this is a characteristic feature for lymphocytic colitis. No basement membrane thickening here. So we would see in the next slide, here this is a high power view of another case to show the intraepithelial lymphocytes. Here, this is basement membrane thickening. And with minimally increase in intraepithelial lymphocytes compared to the previous two slides. So this is a collagenous colitis here. This is the subepithelium collagen band. This subepithelium collagen band now in this photograph looks continuous, but it may not be continuous. It tends to be very patchy. But the thickness also is controversial. Some of the literature says 15 micron. But in a symptomatic individual, even 10 micron will be significant or adequate to make the definitive diagnosis of collagenous colitis in a symptomatic given case. But literature says 15 micron. So These will be more than 15 micron, but it's not necessary to wait for the 15 micron to come up. 10 micron with symptomatic patient diagnosis. Otherwise, normally it is just 5 to 6 micron thick. So should be enough to make a definitive diagnosis of collagenous colitis, and the patient should be treated, and he will definitely improve with that diagnosis.
We are running out of time. I know you have not covered some of the areas. Maybe we will go back, but there are a few questions. So if you can wind up in another minute or two, and then we have 5 minutes for the questions.
Dr. Goenka, Navneet say he will give me 15 minutes more.
Okay, Mr. Singh, is that okay?
Yes, sir.
All right, so let's do it in 10 minutes and then 5 minutes on the questions.
Okay, five minutes, just few more. I'll go fast. Messen's trichome stain, yeah, characteristic. These are usually CD3. So these are all T cells, the intraepithelial lymphocytes. Okay, another one, cryptitis, cryptapsis is coming up for ulcerative colitis, but cryptitis and cryptapsis can be seen in so many other conditions. So one should never straightforward make a diagnosis of ulcerative colitis, and it should be all the time taken with a pinch of salt. If your pathology counterpart is calling, straightforward a diagnosis of ulcerative colitis because of the presence of cryptitis and cryptapsis, especially in our setting where the histories are not really truly forthcoming. So this is the crypt branching. Okay, villus transformation in a case of ulcerative colitis with all the other changes of chronic colitis and also activity. And these are the crypt branching with dysplasia and cryptapsis. Dysplasia here in ulcerative colitis. Okay, I think this is important for you all to know the DALM and all these definitions. And there is little bit of changes. I think people keep on changing. I am slightly not very willing to. The presence of dysplasia is important. Apart from that, what term you use is different issue. But dysplasia should never be missed. And any kind of different looking mucosa has to be sampled when a gastroenterologist is doing endoscopy. So I think presence or absence of dysplasia is the important point, and any term can be used, but it should not be missed. A granuloma, which is a discrete granuloma, another discrete granuloma. Okay, so this is deep inflammation where the submucosa is involved in addition to the chronic active colitis. It could be anything. It could be ischemic also. It's not necessary that this is ulcerative colitis. Chronic colitis with Pennant cell metaplasia, amoebic colitis, a flaccid. I'll show you the amoeba and pH. These are the trophozoites of the amoeba and pH DNA. A CMV, this is cytomegaloid cells, which are highlighted in immunostaining. This immunostain has turned out to be positive, but many times we do not know. Immunostain may not be positive, even though you have very classic cytomegaloid changes. Okay. And here, this is something which I don't know you all are aware. This is around 5% of individuals. This is common cells, spirochetes. But many people can come with IBS-like pictures. This has to be picked up in a given biopsy because the treatment is very simple. And this is also another spiroketosis. And this is a pH positive, but the fuzzy margin, in a band like a brush border, is not here. This is a fuzzy margin, which is highlighted very well on silver staining. I think then, I hope you all are aware of aberrant crypt focus and microadenoma. These are very important, not only from exam point of view. As a gastroenterologist, you should know what is aberrant crypt focus and what is microadenoma. A polyp, adenomatous polyp. And another thing which I feel very frequently the clinicians have problem is mucosal prolapse, which are very frequently mistaken for a growth. So I think either solitary rectal ulcer or rectal mucosal prolapse, which I have seen in the recent past, I think in 2 months' time, 2 cases. Mucosal prolapse showing this. solitary rectal ulcer with the extension of the muscularis mucosae in between the glands. The glands are very well preserved. There are not so much changes. Maybe there is mild inflammation depending on ulcer is present or not. So very characteristic diagnostic without a history. Another one. Okay, that's all. Thank you very much. That's all, Dr. Gupta.
Yes, thank you, Dr. Kim. It was an excellent, I would say, an atlas almost presented by you. I know there are much more in the histopathology which you could not cover in the limited time, but I would request you to answer some of the questions which are there in the chat box on the top. And it says that I still want to know what is the best way of putting the biopsy. So you did mention that filter paper should be used. But how should you put it on the filter paper and then on the formalin? What should be the way?
Okay, actually, basically, it should be the gastroenterology who is teaching me. I ended up teaching all the time. Actually, when you release from your forceps the tissue on the side, and that should not be put directly on the filter paper. I know that many people put directly on the filter paper. Filter paper cut pieces has to be ready to be released on the clean top, and after that, using our pin, the rounded end, optimally stretch it. Don't overstretch it. Optimally stretch it. Identify the deeper aspect and optimally stretch it. Pick filter paper and put it on the deeper part, the cut surface. Because the cut surface is a raw surface. Raw surface will have a lot of plasma protein. Plasma proteins are good adhesive, so it will remain adherent to the filter paper. And so you would put as such into the formalin. And your clinic pathology counterparts should also know how to handle it. They have to train their technical staff up. In PGI, our technical staffs are trained, so we don't have any problem with that. And so, but the technical staff as well needs to be trained. Otherwise, they will remove during the processing. It should not be removed from the filter paper. It has to be processed as such. Only at the time of paraffin block is made. It has to be picked up and embedded XY so that you get the full thickness. That is the important step. Time of embedding. Time of embedding. That's the important step. Should not be removed from the filter paper at all before that.
Will you also tell us about the crushing of the biopsy when you are looking for antiamoeba histolytica? Do you still do that? That you put the tissue on a slide and then crush it?
Yeah, one can do it. That's very simple. But one has to take the sample has to be proper. It should not be much of necrotic tissue. And usually, ideally, it should be along the edge, border of the lesion, because that's a site where the parasite would be maximum. If you take it from the center, it will be all necrotic tissue, may not have much of the parasite. So it should be along the edges of the lesion. So it can be done very easily, but we don't do it actually.
So the other question is, what is the length of the crypt and the villi, and how do you measure it on the histopathology?
See, I already measure. It's not really necessary to measure. It is a concept and observation which you make. And usually in developing country, we usually tend to have shorter villi. So developed country, they say 1:5. In our country, it would be around 1:3. And so, as I already said, when there is a villus injury, it will not be just only the shortening. There would be many other changes associated with it, increase in intraepithelial lymphocytes, changes in the epithelial cells, and celiac disease need not be all the time with crypt atrophy. There could be normal crypts, normal height, but the patient could still be celiac. And another point which I just want to highlight is celiac disease is never diagnosed in a given biopsy. Celiac disease is all the time made by the response of the patient to the treatment. Similarly, ulcerative colitis in a setting should never be diagnosed in a given biopsy. There are many other conditions which come in the close differential diagnosis. I know that even in my department, there are some of my colleagues who make the diagnosis, but I have been seeing many vasculitis cases which have been misdiagnosed as ulcerative colitis, vasculitis, small vessel vasculitis.
So the other question is that we should be possibly put to the endoscopist also is that what is the maximum depth of tissue one can obtain by endoscopic pinch biopsy? So do you ever see beyond the mucosa or do you get a submucosa tissue in the endoscopy?
I think I said that briefly at the beginning. Usually, a routine biopsy usually has a mucosa and little bit of muscularis mucosae. Submucosa seldom comes. Only when there is a fibrosis, invasion, deep ulcer, and ulcer extending beyond the muscularis mucosae, submucosa is involved, then one can get the submucosa, not otherwise.
So the other question is, when you get a biopsy from the lower end of the esophagus, can we be certain that it's not a normal G junction and it is a Barrett's esophagus?
That
so
is
I think
what
you told us very clearly that the pathologist has to be informed from where the biopsy has been done, isn't it?
Yeah, that's what I said. I should be told. If you say this is from the lower end of the esophagus, I'll need Barrett's. So you have to tell me.
Okay. So again, the question is that do you measure the size of the granuloma or you just go by a general impression that whether it's a small granuloma or a large granuloma when you're talking of Crohn's disease versus tuberculosis?
Actually, I think I know personally, see, Pulimut is my friend. She's my personal friend, Pulimut. Her granuloma size has come up to more than 500 now. And she also says that small microgranulomas can be seen in tuberculosis. So granuloma size should not be taken isolatedly to make a diagnosis of Crohn's. Should not be taken. She herself is coming up with all those observations.
They wanted to know, how do you identify Brenner's gland? You did show a slide, I think, on that.
Okay, actually Brenner's glands and enteric glands are the same type of glands. Both are mucous glands. Brenner's glands are present in the duodenum, submucosa in location. They have similar chemical properties also, and enteric glands are usually present in the lamina propria. And so that much I can say. Otherwise, the rest you have to sit down and see the slides.
Okay, thank you, Dr. Kim. I think in the limited time that we had, we almost covered from the mouth to the rectum. And thank you very much. I'm sure your class was very, very useful to the people. Any last minute comment? Any further comment, Dr. Kim, before we wind up?
Oh, no, it's